Thank you all for joining us. Jason, you are welcome to get started whenever you'd like.
All right. I'm Jason Arthur. I'm the AEUS Education Officer, and this is Petra Duran-Gehring. She's the AEUS President. This year, we want to host a number of webinars to try and kind of expand the outreach and help provide some kind of ongoing sort of connection amongst the members. One of the things that we thought would be really great would be to start by talking about ultrasound-guided regional anesthesia and kind of how do we get things started. And so we're lucky enough to have a number of wonderful experts within the Academy, and several of them have agreed to kind of come have a panel discussion with us and have a conversation, hopefully, about, how do we implement this in the emergency department. Unfortunately, a couple of our panelists are running a bit behind, so, we're going to press a little bit harder on our three panelists. But gentlemen, I'll let you introduce yourselves here and tell us a little bit about yourselves, and then we can hopefully get started and have a conversation. And if there's disagreement, that's wonderful, right? That's kind of where we're learning things. If there's clear consensus, that's also fantastic. So Andrew, you want to start us off, buddy?
Yeah, sure. Hey, everybody. My name is Andrew Goldsmith. I'm currently the vice chair at Leahy Clinic outside of Boston. I was the former chief of emergency ultrasound at Brigham and Women's. I have been doing nerve blocks since now residency. I started a nerve block program at MGB that's now gone from probably 50 blocks a year to almost 500. And I've started the national registry as a result that compounds about 15 sites almost now of their national block data for research purposes, and hopefully a couple publications will be coming out this year as a result. But it's great to meet everybody.
Arun, would you like to introduce yourself?
I'm Arun Nagdev. I'm at Highland Hospital. We've been doing blocks for a little while there, probably since 2005. And I'm the ultrasound director at the institution. And it's a pleasure to be on because I think there's a huge utility of this nationally. And I think everybody's finally figuring out the utility of offering multimodal pain control. It's unfortunate that the opioid crisis had to bring us to the forefront, but I think this is the way that we really should practice medicine and emergency medicine.
Hi, I'm Rob. I'm Rob Farrow. I'm the program director at Mount Sinai Medical Center in Miami, Florida. I actually did my fellowship under Arun at Highland and really tried to bring a lot of the techniques that they were doing there out this way. Definitely in a community academic setting, which has been kind of unique, but I think that's more reflective of, how a lot of us practice. So I think there's some insight that can come out of that.
Awesome. And then our other two panelists who are running a couple minutes behind are going to be Joe Brown. Joe is at the University of Colorado Anschutz Medical Center. He's done a bunch with nerve blocks and teaching nerve blocks. And then Lindsay Taylor, who is the fellowship director at the Virginia Commonwealth University in Richmond, Virginia. So they'll be joining in and kind of tagging in. But that way you guys kind of know who they are. Petra, do you want to introduce yourself as well and kind of tell us you're our leader, right? So, I'll direct the panel, I guess, but you're the boss.
Hey, I'm Petra Duran-Gehring from the University of Florida in Jacksonville, and I'm currently the AEUS president. I'm a big fan of nerve blocks. I think this is a great panel, and I'm really excited to hear what you guys have to teach us.
All right. And then for everybody who's kind of watching along, if you all have questions, feel free to dump them in the chat, and then we will kind of keep an eye on it, and we will try to kind of throw those out there. But the idea, again, is that this is conversational in nature. So I'll throw a couple of questions out just to get the ball started. But if you guys kind of feel like, hey, we should talk more about this, then let's go there, right? Because I think this is a really incredibly valuable thing for our community. So I think probably the first thing, and something that we talk a lot about as educators, is like, how do you teach people regional anesthesia, especially in like a department where you have multiple learners of like, residents, but also maybe you have faculty who need to learn as well.
I can take that. I think this has been a question that has been out there for a very long time, right? I think it doesn't really, I hate to take it away from the nerve block space, but I think this pertains to any new skill. I think from central line placement to peripheral IVs to TEE to anything that we do in emergency medicine, I think we're really lucky that we have. I think we're all ER physicians because we like to think outside the box and improve care and try to find, I always tell my residents, we get into bumps and then we get around them. That's our job. And I think this is the same thing. So I think how to get large swaths of people educated is a real conundrum. And I think that it really stems from training down to train up. And I mean by the fact that if you're residency leadership, if you're in ultrasound leadership, training your most junior people, doing a femoral nerve block last night on a lady that had a hip fracture with my PGY1 actually makes her recognize the utility of it and also to recognize the multimodal capacity of this, right? Like the fact that we reduced opioid use, we did all this stuff for her and she really was happy. The patient was really happy. I think filters up. And I'm going to tell you, I'm at Highland in this 2005, we started doing blocks. It's 2024. I can name probably 4 attendings that don't know how to do blocks. That's just not going to happen. I would love to, everybody wants to brag about their department. I want to be honest. And I think this is I don't want you guys to go home and be like, we're never going to get there. You're going to get there. You train the people that want to learn, that For my junior residents, pain control is a block with opioids, with ketamine. It is not the way that we taught it before, which was opioids, reevaluate opioids. So I think that if you change the mindset in smart, young learners, they will be the leaders 10 years from now, and they will also train everybody else. So I think it has to be a mind shift, and I think it's slow, steady. It's not going to happen in 3 months, and train who wants to learn.
Yeah, I think like just following up on that, I think what's nice about regional anesthesia in general is that there's definitely a positive feedback loop where you're seeing a benefit clinically with the patients, the way they feel, the interaction, the ability, like the different options you have available, the multimodal aspect of pain control. So I think you can actually like target certain blocks to kind of introduce into the department, kind of get buy-in that way. And I think things just naturally tend to grow because like, oh, wow, doing that forearm block's pretty easy, or doing the fascial access, that was really pretty easy. I'm interested. Where else can I use this? And I think there's that kind of natural tendency to just kind of grow.
I completely agree. Nerve blocks in particular are one of the only procedures, at least I know of, where you can take someone's pain and just make it go away and basically discharge them from the hospital. That immediate positive feedback provides reinforcement for your attendings, your residents, your fellows, whoever it may be, to continue to learn. But Arun's right. You got to find champions who actually want to do it. Those champions will continue on and actually teach others. And that's how getting your program up and going has worked well.
The most unsuccessful way to do this is to mandate everybody learn to do neuroblocks and hold them accountable at 12 months. This is the same reason why we hate modules on name X module that we have to click through. Learners are the benefit of emergency medicine. I think that we have the best group of physicians, and to train them to be amazing is just like it's a privilege. And so I think that leveraging your smart learners, you'll go really far. And I think people will be shamed that they can't offer great control of pain control to the 80-year-old lady. And I think that's horrible to do, but I think that's the right way of doing it.
The other thing is it's not just your own residents, fellows, attendings, advocates in other specialties, and think small first. Fascial access blocks are one of the easiest blocks to get buy-in from other specialties in orthopedics. Once they have buy-in, it almost becomes standard of care now for them at the shops on that, where they want it so bad, they basically only want to admit the patient once you've done the block or have plans to do the block. That type of relationship and that type of patterns is how you get more people trained.
Yeah, that definitely changes the paradigm, I guess, when the orthopedist is like, hey, can you do a fascial access block? I mean, that's just a complete shift of mentality. And I think that naturally gets that buy-in.
This is why we created Blockheads, right? We formed an online group, not because of some monetary buy-in or some gain, but we wanted to keep the conversation going. So it is a part and parcel of emergency care. So it's we do a once-a-month Zoom meeting that's 15 minutes long that ideally brings in people to constantly talk about this. So in the same way that you listen to your EM rap while you're driving to work, this is a chance for everybody to get together and just share best practices, help each other, and really grow a community of people that this hopefully will go away in 10 years and where everybody just will be part of it. And so I think it's starting small and recognizing that your department, with all its obstacles, if you just get one or two people involved, it will change the department 5 years from now.
So it sounds like what you guys would advocate is kind of a train the trainer model rather than like a prescriptive, everybody needs to learn X block and then do it. The question that I have, and kind of piggybacking a little bit on what Andrew said, was you set this expectation where your consultants sort of expect that you're able to provide a service 24/7, 365, and you can't deliver that in your department. What do you do? Because it seems like it makes it hard to make a protocol, right? Like, so in my hospital, we have a protocol for like low impact fractures where they all get a block, and like, it seems like it's easy to go, okay, well, anesthesia can do it 24/7. And then anesthesia is getting that experience for their learners, but your EM folks might or might not. And so it kind of seems like it's a little more variability, and that might open you up to turf war. So how do you navigate that? Because I can see where, like, if ortho comes to you and says, we want blocks on all these folks, that's spectacular. But if all of your faculty don't feel comfortable doing it, where does that leave the department?
I think you have to be practical. Basically, work with your other specialists that can do that block and get buy-in with them to create some kind of working document. For instance, if they're in the ED doc can do it first right of refusal. They do the block. If they can't, orthopedics reaches out to acute pain. And it may not happen until the next day, but that's just the realistic component of this. And hopefully that drives that person that didn't feel comfortable doing it to basically say, this is an expectation that some other service in my specialist wants. I need to go out of my way to learn this. Just like we went out of our way to learn intubations, other procedures that we've come up with over the years, whatever it may be, at some point you're going to have to learn, just like point of care is now standard of care.
Yeah, and I think also like you're targeting specific blocks for like that situation. I think that's a very common one. I don't think it's unreasonable to maybe do like a department training or two. We can like specifically target that. And then more importantly, also target situations where you'd want to avoid regional anesthesia and how to properly use your anesthetics. And I think that's a nice safety measure too, once you're introducing this into your department.
And I think it's, if your anesthesiologists want to do all the blocks, great. So let them do all the blocks in the ED. I think that's fantastic, right? The protocol with ortho, all hip fractures get get blocks by anesthesiologists 24/7. I love that protocol. And then when they come downstairs, I'm like, meet resident X, right? They're gonna watch you do a block and learn from you because you're such an amazing teacher, and you slowly infiltrate in that point. And then when they get tired of coming in at 3 a.m. to do the hip fracture, they're gonna get resident X to do the block for them, right? They're human beings as well. So I think having that protocol, if you can get your hospital say all blocks get blocked in 1 hour in the ED by anesthesia, totally go for it. Because you're going to then leverage the education from them. They're going to teach your residents to do blocks. You can be there with them. Your attendings can learn. And it's really about the patient. And in the end, trust me, they're going to be like, go ahead. UPenn years ago used to have every other day, I think. I can't remember. I remember the papers that came out years ago about intubations. One day was anesthesia, one day was ED. And it was classic, right? Like anesthesia didn't trust the ED, but after a little while, they're like totally cool with it.
So a couple of questions that came in the chat. One is, how do you navigate kind of the natural tendency of our, for instance, like orthopedic colleagues to want to get a good neurovascular exam prior to blockade to make sure that there's not a pre-existing neurovascular injury that isn't recognized until after surgery, and that they're not kind of inheriting that complication. I think, and Matt mentioned that, what happens if these patients go upstairs prior to being able to receive that block? I feel like in a lot of our hospitals around the country, that's becoming less of an issue with boarding, unfortunately. But I think it's a really great point, is how do you navigate that?
The wrong answer is to send them 5 articles and tell them that they're nuts, that hip fractures don't cause a decreased neuroexam, that it just doesn't happen. And to argue with them on that is probably the right thing to do medically, but the wrong thing to do when it comes to the personality disorder that's happening, right? What they're saying is they don't trust you on your exam. They're saying it in different terms. And so they're saying, we don't trust you as a clinician. Fine, great. So, I'm happy to have you guys come downstairs. We're happy to hold off. And again, your society says that blocks should happen from the ED. So I think it's great. Come downstairs, do the exam. We're happy to block. And I think that's a starting point. And then I think once they get comfortable with what you're doing, I think they will slowly move to the side. And it's a basis argument. This is the orthopedic argument of all times, right? Like they always say random stuff that makes no clinical sense, but that's fighting back with them. They'll just dig their heels in deeper.
I would add that having a guideline in place that's agreed upon by both orthopedics and adds value in this scenario. So therefore you have that patient selection where they feel comfortable, right? Ours is basically low mechanistic trauma, elderly patients, hip fractures, where there's very little concern for compartment syndrome or anything like that. But anything else, have a conversation. Do they feel comfortable you blocking beforehand? That way, everything is out in the open. It's on paper, and you can go from there.
Yeah, I think if you're like holding yourself to an even higher standard than maybe even our anesthesiology colleagues necessarily do on a daily basis with their blocks, I think that you're eventually going to change the perception, like Varun was saying. Even if they're still a little resistant initially, I think you'll start to get them to get on board. That's kind of what happened at our institution, actually.
Yeah, Andrew, we ended up actually just building that same sort of framework for rib fractures and hip fractures to make sure that we were able to actually accomplish whatever that pre-existing exam was that ortho wanted. And we had them lay it out exactly what they wanted so that we didn't run into that issue, or like you were talking about, where they said, oh, your exam wasn't good enough. We had their chair say, this is what I want in your neurovascular exam. So we check that box.
So I guess 2 follow-up questions to that. You said, have a conversation with them about like, hey, is this okay to block? Is that a conversation you guys would recommend people have in the moment beforehand? If it is in the moment, should it be with like the PGY2 orthopedics resident or general surgery resident, or should it be with the attending to attending conversation? I feel like, and again, some of this is from my own personal experience, but I feel like sometimes, like when you talk to an attending on the other side of the fence, they totally get it, right? They're very reasonable. And I think there's a lot of fear that somebody's, that the learner is going to be held accountable for some outcome and they don't really know what this procedure is and things like that. But I just wonder logistically how that works. And I totally forgot my second question. So I guess that'll work.
Wednesday morning over coffee, it's never with the PGY2 resident, right? I mean, this is never the right answer to have a conversation with the patient at the bedside with the PGY2 resident, right? It's just never, they have no idea what's going on. This has to be a departmental discussion.
Yeah, I think what Andrew said at the protocol, I think that's just so key, honestly.
And I know somebody had mentioned saying something about performing, I can't remember who said it at this point, but performing like almost as high of a level as you can, making sure that the exam they want, I think for a lot of acute pain service, regional anesthesia folks, they'll round on these patients post-operatively. What are your thoughts on follow-up for things like admitted patients and quality review of these blocks? Is that something that you all are doing? Is that something you think is the right thing to do or is unnecessary? Because I can imagine if you get in a room with anesthesia, a surgical consultant or something like that, and then the emergency department, it's like, okay, well, who's going to follow up on this block? Is a logical question. What are your thoughts?
Such a good question, and I've asked this myself. The best solution that I've come up with, and I love to hear everybody else on the panel, is to have a very good relationship with acute pain, because they're the ones that normally will follow this up with either a catheter or another single injection block, either in the operative room as well. It's be very interesting from a research perspective to know like how it works going forward, as well as did they have to do another block, or was the pain so well controlled that they didn't touch it? And then neurovascular exams and stuff like that to make sure no complications occurred, obviously.
I think we talk about this a lot of times as well, though. We have very different outcome goals at times than our surgical colleagues, right? Anesthesia, if they're going to the operating room, they want surgical grade anesthesia. And I think our goal is always analgesia that we're trying to provide. And so I think a lot of times setting into place some sort of order panel or clinical pathway within the department so that you're getting that 30-minute post check is really important. But then we end up just sort of reviewing all of the blocks in our own QA process on the back end. But we kind of own the block within our department. Is kind of how that's landed in our hospital. And again, we're just trying to get analgesia. Like my hip fracture patient, I just want comfortable through the night, so I don't have to give as much morphine, Dilaudid, fentanyl, anything else. My goal is analgesia.
Arun, either you have similar opinions, different opinion?
Yeah, no, I completely agree with what's been said. One step that we did just for rolling our program out, we really weren't doing any nerve blocks here not so long ago. And I think now we have a fairly robust ED-based ultrasound-guided regional anesthesia program. One of the steps that we took to maybe alleviate some of those fears is we actually did patient callbacks on all of our nerve blocks. If not that, then a chart review if they were admitted. There's limitations that inherently, but I think that it did offer a bit of reassurance and also safety, but also I think it was a good educational aspect. That's kind of a thing that we mandate with any resident that does it, that they do those callbacks within a 24 to 72 hour time frame. It's more work, but I think it really did show that we were doing our due diligence, not only just on protocols, but also really kind of thinking about the patient beyond that initial block. And I think it really alleviated a lot of the issues that we were initially facing.
Yeah, we don't follow up all of our blocks. I think we have too many and we've been doing it for too long. I hate to say that. Our colleagues inpatient follow up the blocks, and if they have any persistent neurological deficits, they get a hold of us. It's in the same way that if I put a chest tube in or do a pericardicentesis, the other service is going to take it and they'll get back to me if there's a problem. And that we document all our blocks, so they're all templated, really simple, so they're in the chart so people are aware. So we haven't had any of these cases. For discharge blocks, we use Epic, so we have an ED block discharge instruction set that I made that we just in our notes, so everybody gets this long conversation that's it's not long, but tells them to take pain medication even though they're numb, tell them to come back in 48 hours if they persist to be numb, or if they have any weakness. So we use those two methods. It's not perfect, but I can tell you from the case of a block gone awry at major quaternary care top 5 medical center in the world, that when they did a block on a resident and had a post-operative PNI, a peripheral nerve injury, when that resident went back to anesthesia, they're like, that's not our responsibility, peace. So I don't think that we're operating anything that's loosey-goosey or different. I think very few anesthesiologists follow their blocks post-operatively and from numerous colleagues and deal with the post-operative complications of those blocks. I mean, I'm sure there are some, but I don't think that's common.
Yeah, I think that's really valuable insight, and this makes you wonder from a policy standpoint if we shouldn't consider like things like a clinical policy and kind of a model of discharge documentation.
Yeah, I think even the stuff that we're doing with our registry, with blockheads, with education, say this without putting a feather in my cap, it's much farther ahead. I mean, this same idea that POCUS, right? We took POCUS from really nothing to something, and now it's the model for every single specialty in the country. We're doing the same thing with this kind of skill acquisition. So I think that we're actually doing something that's really novel and actually probably better for patient care than a lot of other societies. And I'm not trying to knock them. I think they just do blocks and then they let it roll.
I think that's a pretty fair assessment. And then Petra asked what I was thinking too. I was a little bit nervous to ask, but would you be willing to share your discharge instructions as an example? Because I think a lot of us would find some value in that.
Yeah, I'm sure I have it somewhere. If you just shoot me an email, I can send it to you. It was just us sitting around the table talking about it and saying, what are the things we worry about? One is if they persist to have numbness and pain 2 days back, and really help them. This is actually coming from a paper I read from a physician. I think you may have been on the paper, Andrew. It's with bounce back pain, and people were not taking oral medications, so we would block them, and then they would not take the Tylenol ibuprofen because they were painless. And then the pain would come back even stronger. And this happened to my chair who had a brachial plexus block for a shoulder issue. So we were just like, my chair doesn't figure this out. We definitely need to have more instruction for our patient. So it's one for bounce backs for that, and second for like pain management during that process.
Awesome. Yeah. And then Christine asked about would it be something you'd be willing to blast out over a listserv at some point?
Yeah, I mean, I made it up, and it's essentially a dot phrase on Epic. Cool. So I can definitely share that. Just reach out to me afterwards. I'll send it by email, and then you guys can post it.
Fantastic. I'll make that happen. Sandy asked, is anybody doing blocks, like emergency department and physician wise, doing blocks outside of the emergency department? It sounds like maybe a relationship with our acute pain service. So rather than kind of going, hey, is it our block or your block? It's kind of, we all do blocks, and then kind of expanding our footprint throughout the hospital rather than just ED based. And Sandy, correct me if I'm wrong there. It's a great question.
No, you're good. Our anesthesiologists just can't seem to get to do these blocks. So we were asked by the trauma service and then the ortho service, could we come up to the floor and do a block? And we were like, oh. So we started just doing them, and we had intralipids put into all the Pyxis up there, and and so anesthesia was like, well, why aren't we doing these blocks? And trauma said, well, we consulted you on these 5 and you couldn't do them. And, they had already left the ED, but had multiple rib fractures. And so we started doing them, and then we met with anesthesia, and they were like, oh, this seems like a really reasonable idea because we are not available all the time. And they helped us develop the consult note and a consult service so that we're actually on call through Epic. We've just started to do this. So it's pretty new, but I'm just curious if there's anybody else who's doing that so we could learn from them.
That's amazing. That's awesome. I love that story.
Sandy, it sounds like you're going to submit an SAEM innovations this next year for SAEM 25.
Yes, I think we are going to submit something for sure. But yeah, it was totally amazing. Once they figured out we knew what we were doing when they asked about intralipids and all of that. And we said, well, we had them stocked in the Pyxis, and they were like, because they take theirs up with them, but there can be a reaction like an hour later. And so they were like, that's a really good idea.
Yeah, we've been doing this kind of off the radar for about 10 years. I know Rob, when he was a fellow, did a block in ortho clinic. I think that was you. And so we've been doing this for a decade upstairs because we don't have a pain service. And I think you have to go internally to your hospital and see if something bad goes on upstairs. That has to be worked out. But I think this is why I think emergency medicine is amazing. It's like we're able to cover hospital services that can't, and we're willing to go and help people for pain control. I think you did this for a fracture reduction upstairs in ortho. We've done numerous ribs, serratus and erectors up on the floor in the ICU, central lines. We used to do a lot of joints upstairs. When ortho couldn't get a joint tap, we'd go up there and help them and do the joint tap, or if anesthesia or somebody would call us. So I think this is exactly the collaboration that needs to happen at academic and non-academic centers to really make people recognize that what we're doing is something that's really about patient care.
Yeah, and I think like you said, being thorough and like thinking a step ahead and thinking about possible complications and how to mitigate that. It just shows that level of professionalism. And I think beyond that, we're just so well suited for this because it's a skill set that we're already good at, right? Point of care ultrasound is already part of our curriculum. we're extending similar techniques that we use all the time. This is definitely a space that really all our physicians should be able to do. Yeah.
I think
we're definitely not doing them off the floor yet, but we do a ton in our op zone is like a great place for all the people that get kept overnight for MRIs, for subacute back pain and all the rest of that. And so that's definitely a great space that we use.
I think Sandy hit on something as well and talking about equipment and medications and stuff. Are there any things that you're like, this is the minimum stuff you think you got to have, right? So like, and what's the maximum, right? So like, are you like, hey, look, you've got to have blunt tip needles that are, hyperechoic on ultrasound so you can easily see them, block needles, right? Like we use Stimuplex. There are other brands, but that's what we have in our shop. You got to have interlipid in your department or in your cart or whatever you're using. You got to have a cart or no cart. Are you guys like, are y'all putting catheters and putting like on-cue pumps in? I mean, I'm curious, where the spectrum lies, because I feel like it's something that it's very easy to get a little overwhelmed and be like, wow, there's a lot of stuff I got to go through P&T. I know in my own shop, I went through P&T to get ropivacaine added to formulary whenever I came on staff. But, you can make an argument for a multitude of local anesthetics and adjuncts. I'm curious what you guys think. What is the sort of core complement of equipment, medications that we should have for an ED-based block program?
I mean, I think the minimum is if you do a block, you need intralipid in your department, just in case something goes wrong. Everything else is very beneficial, but is not as necessity as having intralipid, making sure a patient's on the monitor, making sure you have IV access if it's a large volume, just in case. You never want to be caught looking for these things in case something were to go wrong. We have a cart, we have Sonoplex needles, we have like a kit made up, so it's easy grab, easy go. I'm working on currently getting a lockbox. I think Arun has one where the anesthetic is already housed in the cart itself. So you just push the cart and go. But otherwise, we worked with Bupiv, and at my new shop, we have Ropiv. And so those are the two main medications we have. And then dexamethasone for adjuncts.
Yeah, I was gonna say, I think like how you kind of did that progression is kind of what we experienced too, as far as kind of how to set it up. Like that's the backbone that you have to have. Everything beyond that is just about obstacles that you're knocking down that are like inhibiting people from being able to do it effectively and kind of grow the department and that skill set.
Yeah, I think that's how we approached it as well. We did a block cart so that it was a one-stop shop. You didn't need a Mayo stand. You had everything there for you. We had pre-filled out discharge instructions already in there. We ensured that we had intralipid in all the Pyxuses in the department. But then for our shop, at least, if you're going to do any sort of compounding of meds, so adding dexamethasone, for example, the pharmacist has to do it. And so we created new order panels that basically allowed us to do that so that the pharmacist could sort of expedite making meds as soon as we decided to do a block. And it also wound up including all of our nursing orders pre and post block, very like discreetly labeled so that we are getting pain scores, we're getting weights, we're getting vitals all monitored. So we haven't had any episodes of last up to this point, but it's, it felt like the prudent thing to do as we're starting to definitely have a larger footprint at our shop with doing this.
Yeah, we kind of did ours in a stepwise approach too, where, we knew we'd get a little pushback on ropivacaine initially. So we just went ahead with bupivacaine and lidocaine in the Pyxus, readily available. And then, once you start to get buy-in and show that, you're doing a fair amount volume-wise of this, then you can start pushing, for other resources to be made available.
Then a couple of questions that came in here. John Bowling said he works in a smaller shop, doesn't necessarily know that they have interlipid. I would say, John, you probably actually have it in your hospital because it's part of TPN. It's the base mix. It's just probably something that nobody really thinks about to use in this application. So you probably actually have it on formulary already, and it's just a conversation with pharmacy. But assuming you don't, would it be okay to do small volume blocks? What do you guys think?
So I agree. It's going to be there. I'm sure 100% it's there. And but we looked at the pricing on it. It's $2, shelf stable for 6 months. So I would be very surprised. Yeah, exactly. That you don't have it. And personally, I think if I was going to, hopefully this is recorded, obviously, but if I was going to do blocks and I was going to go to some random hospital, I would just throw a little bit interlipid in my backpack and just have it there. Do I think it's safe? Probably, but why not, right? Like, I mean, the last thing you want to do, have an event and you're like, oh man, I have an antidote. It's just not in my hands. So I would just, it's $2. You probably buy it on Amazon. I don't know. You have it in your backpack and just keep it there when you're being the rural cool doctor working random spots.
Yeah, it's the cheapest insurance policy you can probably find these days, I would think.
$2.60 or something, $2.60 for one of these bags. That's how much our pharmacist told us we pay for it.
Yeah, and I think that'd be a hard one to get any pushback on if you requesting that to be stocked in the department. I feel like that'd be hard to get pushback.
Yeah, and there's several questions about adjuncts as well that folks are kind of wanting to know. What adjuncts are you using? Is there specific cases where you are or are not using them? Is one that comes to mind for me. And then I think there was one about like, when do you add them? And are there additional adjuncts other than dexamethasone? So are you guys using morphine, ketamine, Presidex, anything like that in your adjuncts?
Just Dex. That's all we do, and I think it's a useful tool for almost everything. If you want a prolonged block, I think it's a reasonable dosing. I would use a low viable dose. People always use too much Dex.
We use Dex, milligrams to 10. I mean, is what the studies are. There's a Cochrane review on this with low to moderate evidence that dexamethasone improved half-life by up to 8 hours. I think there's additional benefits that we probably don't know about because some of these patients have pain longer throughout as well, like an anti-inflammatory effect. But I think Maroon's right. Lowest effective dose here, our vials are 4 milligrams. So it's just easier to start with 4.
Yeah, we've got the 4 and 10 milligram vials. And so we're using it for any of our sort of longer half-life blocks. We pretty much add it to all of our fascia iliacus, serratus, spinate blocks at this point, transgluteal side. Pretty much all of them. It's getting mixed in if we're looking for a longer duration.
Just dexamethasone. This is actually kind of where the callback was a little interesting, although I completely agree with Ryan. I think the sustainability of that long-term is not realistic, but I think as an entry point, if you're introducing to a department where you aren't really comfortable with that, it really gives you an idea of which patients you might be thinking, okay, I might like to add dexamethasone the next time I do this block, or that was actually surprising. Maybe this patient actually did okay without, when I called them back, their pain's controlled after being in a splint and getting that immediate pain knocked down. So I think it kind of helps you fine tune where it can be useful.
Yeah, I think that's really valuable insight. And then Joe, I meant to ask this and I apologize. It slipped my mind, but to put you on the spot the same way we put Arun on the spot, would you guys be willing to share like your order set that you guys put together as kind of an example?
We've got our order panel, and then we also just updated our rib fracture, geriatric hip fracture, atraumatic low back pain, and pelvic fracture pathways. So it's all included in those as well.
Oh, that's fantastic. It's absolutely fantastic.
Yeah.
One of the questions kind of hit at two things that I think probably a lot of us get a lot of pressure on, and that is documentation, billing, and then kind of that trade-off of like the block versus the next patient. Right? Like, so how do you guys balance that? Right? Like, I feel like there's a lot of financial pressure in healthcare right now, but also there's a lot of pressure to kind of meet the metrics, right? See the next patient. And so how do you guys navigate that?
I think like the block card, honestly, is like such a huge part of that. I think you have to remove any obstacle you can to make it practical to do it quickly. Actually, a fair amount of our blocks are done at freestandings by attendings working on their own. And I think once you figure out how to work this into your workflow, I think it's definitely practical and something you can do. And I think also keeping in mind that not every block is going to be like a high level or a high volume 2-person approach, right? The majority of these are probably going to be brachial plexus blocks, forearm blocks, blocks that you can do with relatively low volume and do it quick if the resources are available.
Yeah, I mean, I think the problem with most of what we do in emergency medicine is you're just doing something as simple as a laceration repair, right? It can destroy your shift. It sounds silly, but you have a complex laceration repair in a 65-year-old patient, you have 7 patients to see, you're done. If somebody can walk in the room and, have all the supplies set up and has already numbed the patient up or irrigated, and you have to throw some stitches in, it's a different ball game. So I think thinking of the term is called user-based design. So thinking of it from the user base, like what's the easiest way for you to get the resident or yourself to do that block, and trying to take those barriers off beforehand. So when it comes to having everything ready for you at the bedside, having order sets, having discharge instructions, having documentation, and you can just pick one, and it does not be all of them. Nobody's perfect, but to reduce that barrier, all of them are just barriers to getting something done. I mean, if there's one ultrasound machine and you have to charge it up every time you use it, guess who's never going to never going to do a gallbladder exam, right? Me. If you have to go find the system in a different department and load, it's the same thing. So I think trying to think from the user's point of view and just knocking down the little barriers will make it much easier.
It's an interesting question you just asked right now, because I just got my financial data for the first month being full-time at Leahy. And just from a financial perspective, nerve blocks are 1.5-ish RVUs, which is about a little bit more than your medium visit level 4 coding. And so if you think of it like that, you're seeing that next patient, doing the nerve block may be a little bit worth more, just if you're putting it from a numbers perspective, and that's your major drive, in addition to everything else.
Yeah, and I think, Andrew, like building on even the simple blocks, like the forearm and the posterior tibial blocks, once you're doing those, if you're thinking about trying to remove like a foreign body from somebody's hand or from somebody's foot, like a big shard of glass, so you have a complex lac, If you think about how much better analgesia you're going to get from a block, it actually may make the procedure itself faster if you do the block, go see somebody else, and then come back in 15 minutes and then sit down to try to do it, as opposed to doing the incremental injections of local lidocaine. I found I've had a lot better success with complicated procedures that can also be a complete time suck when you've got a lac across somebody's footbed that you know is just going to take forever. It can actually expedite some of the procedures if you sort of work them into your flow.
I think that's incredibly valuable insight from everybody. Backing up a little bit, Petra had asked me, for example, have any of you guys in your experience, and you all have had pretty impressive amount of experience, had to use interlipid? And if so, how many times are we talking over the course of years? Like, is this something that departments should expect to see once a year, or is it something they should expect to see once a decade? Is it something they should expect to see once in their career? Just to give people an idea.
Yeah, I think that the data from large sets, it's pretty rare. We had a case of it where we used it. We had a case, and it really depends on how you define last. I mean, this is the difficulty in most things. How do you define a compartment syndrome? It's a really fuzzy math on this. So we had a case where we had a patient that started having hypertension, tachycardia, and some tingling, and interlipids were pushed with an electrospinate that was given with large volume. We had a patient that went into full arrest and needed CPR, and interlipids were pushed, and the patient came back. So we've had now 3 cases in 15 years. Not ideal, but each of those cases, the patient did really well with us training. And actually, these are all being published, so you'll get the whole case rundown publication, and ACEP now is coming out about it. So just to give all of us how to do it, how to stock it, and when to think about it. I think it's something we should be aware of. We're the experts in this.
Yeah, and you said your shop's doing about 500 a year. I imagine you probably didn't start out there, but probably
500 to 600 a year. I think this year was 7, but not all of them sometimes get in the registry, but yeah. So in that number, so it's a pretty large amount. We had at UCSF, they had somebody come down in full arrest from a block that the ED pushed interlipid on and reversed them. Were you there, Joe, when that happened?
It was like a cervical block or something, or some other block in a different department.
I've had friends in different areas, but I think that the key is everybody is understanding that it's not just a seizure and cardiac arrest, and then the downsides of pushing interlipid are almost zero. And so I think that just having everybody aware. And this is this is the Crike phenomenon, right? If you don't know how to do a Crike, you'll wait till the person's satting at 60% before you let's do a Crike. So I think you just have to be very aware, very conscious of it, and have everything ready.
Yeah, we've only had one case and starting about 4 years ago. It was also an electrospinate, which I think that's another part that's really important with your education. Cervical block, electrospinate, like anything that's near central nervous supply or large volume, that should be higher on your radar, and you should be taking precautions. I think there's definitely an element of safety that you have to make sure that you're expressing to your department.
I think the other thing that I've heard described, go for it, Andrew.
In the registry for the first 18 months, we have only 1 case of interlipid, and it's the one Arun's referring to. There was 10 complications, 1 interlipid blast syndrome, and the rest were very minor, like foot drops from a transgluteal sciatic nerve blocker a few times, stuff like that.
Wow, that's great.
I've heard of it described as is every case that we push epi full-blown anaphylaxis? And no, sometimes we intercede earlier. And so just because you're giving it's like where on the spectrum, it's a last is the spectrum. And so giving it earlier doesn't mean it's necessarily full-blown cardiac arrest, but it's better to treat early.
I think that's great. So I think from a training standpoint, I know you guys said, you talked about kind of taking motivated learners, specifically it sounds like residents and fellows who are really motivated, want to learn the blocks, want to put it into their practice, and kind of using them to sort of provide upward pressure to kind of encourage your departments to do that. How do you guys approach teaching blocks in your department, though? And I'll put it in very clear terms. I worked a shift yesterday. One of my partners was like, "Hey, what do you guys want to do for faculty development this year?" And my partner said, "I want to learn regional anesthesia this year." So it's like, great. Okay. How do I teach that, right? Do I teach them 1 block? Do I teach them 10 blocks? Do I take them to a cadaver lab? Do I come hang out with them on shift? And when something rolls in the door, do we do it? How do we do that? What is y'all's approach, having trained a number of people in regional anesthesia?
I'm going to say less is more. I think when you train people for a lot of things, this is, my first year residents, I want to learn everything. I'm like, great. I think you have to recognize that from your own evaluation of what comes into your hospital. If it's a lot of hip fractures, a lot of rib fractures, here's 2 blocks that we can kind of pick up. I think most of those blocks can be done either at courses, it can be done in anesthesia, It can be done when you're working clinically together and you walk him or her through a fascia iliaca or a serratus. Really simple, get needle visualization, understand the basic idea of what you're doing, and then get them comfortable with a couple core blocks that you feel are common at your institution. And I think that that person will come back to you and say, can you teach me more? And I think that will happen pretty exponentially once you start doing the basics. I think having a novice provider do an advanced block that's very needle visualization poor just makes them scared. And we've all done this, right? We've all been junior learners and had somebody do some really esoteric procedure with us and be like, what the heck's going on? And you're not seeing this, you're not seeing that. And then you're just like, I'm scared of doing that. So I think it has to be a skill acquisition, simple, to the point, and really has some low risk for error.
I think we've gotten better at teaching them as well. Like I think back to the original suprainguinal fascia iliaca bow tie thing that freaked everybody out. And I think the more we approach all these procedures as riffs on things that we already know, so doing the infrainguinal fascia iliaca where it's just lateral to where you do a femoral line is anatomy people are comfortable with. And so that's a nice way to approach procedure that otherwise might be sort of foreign to somebody. And so I think we've gotten better at teaching and trying to narrow it in that sense. But I agree, there's core blocks. It's the peripheral blocks, probably serratus anterior and the fascia iliaca are like 5 or 6 blocks that you can start with. And then it's all just riffs on the same theme. So I think you can sort of slowly add other ones, but it's sort of just-in-time resources. And then the same idea of needle visualization and the difference between a peripheral block and a cone block.
All right, so you're saying pick a couple of blocks. How do you teach it? So do you teach it coming into shift with them, cadavers, just a slideshow? What's y'all's approach?
I have a unique experience because now I've gone from academics to like semi-academics and where it's more faculty run. When I was academics, it was teach the residents the first easy block that they can learn, which drives the engagement from the attendings, teach the teacher model. To your point, faculty development session is how I'm doing it. The least possible, having everything ready for them to go once you teach, and then being available for them as a resource while on shift and in the office to just call, text, to help them with their first couple till they feel comfortable. And once they're a captain, they can then go teach someone else. But we're using meat models for hydrodissection and then finding anatomy on each other, as well as just very short PowerPoint presentation. But this is the exact same model of how we teach blockheads. It's short PowerPoint models, meat models, practice, hands-on experience.
That's awesome. Anybody else have different thoughts? Somebody asked, how do you go about training your faculty? And I don't know if this was directed at me or to the group, to be totally honest, but it says, do you have funding to teach the faculty blocks? Or is it kind of like, you guys are this is part of the role of being the ultrasound faculty. And in your cases, the kind of experts in regional anesthesia that you kind of end up teaching folks? Or is this just part of being an academic attending? What are your thoughts? What models have you guys seen that really succeed?
I think part of like the thing is just time, right? I think that when you have a fellowship or residency, you inherently have scan shifts where you're available on, where you're not carrying a clinical load. But I think that's also kind of what kind of drove us for blockheads for like doing workshops. It's really to provide that time to just get the probe, walk through the anatomy, get comfortable with it. Because like as long as you know your anatomy and you know the technique, it's really not something that's beyond your skill set. And I think it just takes time to realize that and to kind of get over that initial mental fear, I guess.
And I'm going to put a shameless plug here. Right? We run a course, pre-ACEP, pre-SAEM. It's super inexpensive. The idea is not to make cash. The idea is to get hundreds of people trained so they go back and change the world. You come the day before, you spend 3 hours, have some beers, have some food. We will get your novice learner to get basic blocks down their throat, and they'll be like, I can do this. And that's the goal. And so I think we're trying to, again, user-based design, right? Reduce all the barriers. And here's another way. You're going to ACEP, show up. We're happy to have you. If you bring a group of you, we'll even talk about giving you guys a group discount, but you guys know how to get a hold of us. And it is, yes, a total shameless plug, but we want to teach everybody so we can actually improve patient care.
I think that's a fantastic plug and a great reminder. I think like a lot of the programs. I know Joe ran a block course at SAEM the last 2 years. Maroon, that's great to hear that you guys are running one at ACEP. I think it's wonderful to have opportunities where people who don't feel comfortable can go to a course and just, get a big bolus of information. I think probably going to be our last question here is from Petra, and she said, do you make your learners practice needling skills first? And they do kind of target practice. What are your thoughts? Do you have to kind of show that they have competency with needle skills before they do blocks, or you kind of say the block is a way of learning needle skills?
I mean, I would hope they're doing not just nerve blocks for their needle practice. I mean, peripheral IVs, granted, they are a short axis instead of long axis, but there are multiple ways they're getting that practice. But yes, that station is set up with when I do my nerve block courses for faculty development there as getting a long view as well.
I think skill acquisition, if you play around with the needle, a probe, tofu, or meat model, I don't think this is not a big skill. You're a academic or a non-academic community ER doctor. This should be completely beneath your skill level, right? This should be super simple.
We have like blue phantoms that are just kind of stored in the department so that you can, on an overnight, you can just pull them out and people can practice. But I mean, the other thing I always come back to is like, in a lot of ways, doing the bounce jiggle approach to placing a fem line probably fillets more fem lines than trying to do anchoring little fascia iliaca. So in a lot of ways, it's safer than some of the other things we consider a core part of our practice.
Yeah, I think that's a really great observation, Joe, that like that kind of blind femoral line is probably fenestrated a lot of femoral nerves inadvertently as well throughout the years. So I think that's a really nice analogy. I will say as well as a plug, we will probably be doing one of these webinars talking about phantom building at some point this year. So for those who are like meat models, what are those? We'll definitely go through that, and we may do some videos on how to make them. If anybody's interested, please let us know. I think the very last question I have is, how many blocks is enough to kind of cut people loose, right? Whenever they're like ready to rock and roll. So 5 blocks, 10 blocks, 35 blocks. Is it an individualized number, right? Does it depend on the learner? What do you guys, if a faculty member comes to you or a resident comes to you and says, I want to learn blocks, I want to learn the fascia iliaca block, how many are you kind of letting them, scan and sim and kind of walk you through it before you're like, okay, you're ready to rock and roll?
I think it's a great question. I mean, I think when we look at total numbers, I mean, I think when we've written some of our procedural guide, like the paper that Andrew and Arun and I put out a couple of years ago, I think based on other procedures, we had sort of started with 20 as sort of our spot, but I think it doesn't need to be a particular block because in the end, the skill set is the same across all the different blocks. I think we're still trying to figure that out exactly, but I mean, I think somewhere in that 20 to 30 range is at least where I notice with our residents that they seem the most confident and the most adept with the skill of keeping a needle in plane, and they're able to point at a target on the screen and get a needle there.
Yeah, this constant conversation, right? Like, I think that the answer is there isn't a number, but I know that people want a number. So I think the number can be as little as 5. And I mean that honestly, if you do 5 fascia iliaca blocks, I think you're probably good to go. If you're at 10, you're probably pretty good. And after that, and again, I've had some learners who've done 10 who are terrible, and you've had them too. You've had your resident who can't get a person along who's been doing this for 3 years. And so I think it's just a part of the deal. So I think we're going to put some number down the same way that ASAP put down 50 or 25, but I think that number is going to be variant on the person and then their skill level.
Awesome.
Well, thank you everybody for joining us today. And there's been a lot of great resources that have been kind of discussed. We'll make sure that we put together a document for everyone who's been on this call. Thanks a lot, guys. We appreciate it.
Thank you all for your help.
Thank you.
Thank you.